Good morning, ladies and gentlemen. Today my talk is technical tips and tricks for various hepatic artery anastomosis. I am no COI. Hepatic artery complication after living donor liver transplantation are potentially lesser, occurring in 2.5 to 9% of cases. Sometimes the native hepatic artery is unusable due to prior intervention like chemoembolization, radiation, or intra-arterial chemotherapy. In this situation, the alternative artery is needed. The right gastroepiploid artery is most commonly used due to its accessibility and adequate length, but if it is unavailable, the best alternative remains unclear. The frequency of hepatic artery thrombosis ranges from 0 to 10%. Hepatic artery thrombosis is highly fatal, causing significant impairment of liver function and require reoperation or intervention. If left unresolved, it may lead to retransplantation or death. Artery structure oxygen leads blood away from the heart to various parts of the body, including intima, media, adventitia. The intimal endothelium possesses antithrombotic properties that help prevent blood clot formation with the arteries. Endothelial cells produce substances such as procyclin and thromboglobulin, which inhibit platelet aggregation and activation, thereby reducing the risk of thrombosis or clot formation. This is the basic principle of hepatic artery anastomosis. After placement of the approximate clamp, state suture at 0 and 108 degree are placed and cut with a long suture stump and for retraction. Then the first suture will be middle of two-stage suture and not tied for easy visual inspection or posterior layer. The second and the third suture will be between each stage suture and the middle suture. After evaluating the orientation of the sutures, free backward or confirming correct suture placement, the second and third and the middle suture are tied at least 3 times. A surgical double tie is a helpful suture with tension and size mismatch. The approximator is rotated and the above steps repeated for the posterior layer, which is now anterior position with rotation. This is continuous technique. Continuous technique has several advantages. It is faster and provides easy adaptation to size mismatch. This is the basic principle of hepatic artery anastomosis. A successful hepatic artery reconstruction has 3 key factors. First, selecting the appropriate recipient artery, and second, the quality and the length of graft artery. Third, the selected anastomosis technique. The setup for anastomosis is critical. A surgeon must navigate several challenges inherent to the produce, such as a deep or moving surgical field, a variable graft, and the recipient best quality and complex anatomical orientation. The size and quality of the graft artery largely determine the choice of inflow arteries. Therefore, it is essential to preserve all 3 hepatic arteries, the left, middle, and right, along with the secondary branches during hepatoduodenal ligament dissection in the recipient. This is a beta systemic review by PS surgeon. A microscope is better for the hepatic artery anastomosis. This study examined the most recently published systemic review paper on the topic. A total of 45 studies were finally included, including 8,000 individuals. During liver transplantation, recipient primarily used the right hepatic artery, followed the left hepatic artery as a second choice. In the group of that utilized Loupe for the hepatic artery anastomosis, the incidence of hepatic artery thrombosis was 8%. In contrast, when microscope was used, the incidence was 4.2%. Especially in plastic surgeon, the technical failure rate was significantly lower than 2.6 when a microscope was used. This is my actual video clip of hepatic artery anastomosis using microscope. In the recipient surgery, I prepared the right anterior and posterior branch. After checking the size of the grafted hepatic artery, I decided to cut and perform anastomosis at the level of right hepatic artery. The anastomosis preparation is started to graft artery evaluation. Arterial end should be trimmed to have a smooth anastomosis interface. Flushed with heparinization cell line and gently dilated under magnification. Any class removed as well as adventitial tissue around the arterial orifice that could interfere with the anastomosis. The approximator clamp is placed about 1 centimeter from the arterial ends in both sides. We prefer the place to 2 cm of rectangular mat cut from satellite globe for the background contrast. Before starting anastomosis, it is extremely important that the position is convenient for the surgeon. The anastomosis site is tension-free and stable as much as possible. We prefer 90 nylon for the 1.5 to 2.5 millimeter and 0.2 nylon for the 1 millimeter diameter arteries. Surgical knot, particularly double tie, is beneficial in the suture involving tension and size mismatch. After completing the anterior wall, rotate 108 degrees to ensure secure and suturing the inner layer of intima. Proceed with the suture posterior wall as well as. After completing the posterior suture, release the clamp and inspect for any areas of bleeding. If bleeding is present, additional interrupted suture was performed. Once the suture is finished, releasing the inflow clamp, it should result to first time pumping an artery and confirming adequate blood supply to the bile duct surrounding. Recent study showed that there was no significant difference in the incidence of hepatic artery thrombosis between use of a Loupe and microscope. The paper reported no significant difference in blood flow or structure rate between two techniques, but surgical procedure utilized the Loupe were favored in terms of anastomosis time. In recent system review paper, post-study report that hepatic artery anastomosis using a microscope result in lower hepatic artery complication rate compared to using Loupe. However, some studies not. According to data presented at Seoul St. Mary Hospital, even when continuous suturing using parachute technique was performed with Loupe, the probability of hepatic artery complication reported 1.3%. This is a study indicating the pediatric cases, the use of continuous suture under Loupe show no significant difference of hepatic artery thrombosis. This case is my case is by Loupe. Sorry. When the artery size do not mismatch, one option is to cut oblique to adjust the diameter. However, I find that 1 0.2 mismatch can usually be managed by using corner stitch on both sides or by H0 proline. Personally, I tend to use continuous suture in the liver transplantation from brain-dead donor, but in living donor liver transplantation, I follow a similar process using the microscope for the overall procedure. When they're using a loop, after performing corner stitch with H0 fluorine, and it is convenient to hold in place the mosquito clamp without tying immediately. This allows smoother progression of the suturing. After finish the anterior wall, rotate the artery to the backward, ensure secure suturing the inner layer of intimal. Almost the same to the microscope. You can see good patency regardless of size mismatching. First, you can see the pedicle of left to we release only the clamp, the graft hepatic artery to check the bleeding site through back below. In this particular case, the graft hepatic artery was slightly injured, so we observed more bleeding than usual at this step. Now, this situation required careful handling. If we take a deep bite, the posterior wall can be taken together, which is risky. So on the other hand, if the bite is too shallow, we may fail to catch the intimal, leading to the dissection. To avoid both these problems, we use a figure-of-8 technique, placing two sutures, then tying them securely. As you can see on the right side, after confirming backflow and making sure there is no problem, we slightly release the inflow clamp to check for any bleeding point. Once the bleeding site is identified, we reapply the clamp and perform additional line zero sutures, which allows minimize unnecessary dissection and reduce the risk of injury. If there is only minimal bleeding from the needle puncture site, instead of future dissection, we simply apply the hemostatic agent with gentle compression. If the native hepatic artery is unusable, alternative inflow source must be considered. The right gastric epiploid artery is often selected, but any artery is usable. In this case, is the right gastric epiploid artery, which is the most commonly used alternative when the right hepatic artery cannot use. The right gastric hepatic artery originated from the GDA, so the artery and the vein stump along the duodenum, and the microscope step is same procedure. Next cases is the mid-colic artery cases. This case is the HCC patient with CCRT. So GDA cooling, and you can see the hepatic artery hepatic artery is very bad patency for the angiographies. So you can see the another arteries is not available. So mid-colic artery is larger than other arteries. So in these cases, we palpitated right gastric epiploid arteries. It was very weak. When isolated, the flow was very poor. So we proceeded with the mid-colic arteries planned, and during isolation, we applied clamp. and monitoring the colon for the color changes and minimize the risk of arterial injuries. The anastomosis process has been shown extensively before, so I will omit the detail here. As you can see, the shape and the angle is good, and the final outcome also not bad. Last case is a pediatric patient who developed hepatic artery thrombosis after an initial anastomosis was performed by a pediatric surgeon and prompting them to request my assistant for reoperation. You can see the hepatic artery, the completely occluded by thrombus. We resected the and affected segment and used the donor side with progatic catheter. Remove the thrombus and confirm the arterial fluid. Because the hepatic artery in this case is very small, we generally avoid using balloon catheters. The recipient common hepatic was not suitable, so we decided to use the splenic artery as an alternative inflow. We harvest the splenic artery along the upper border of the pancreas. This case is a pediatric liver transplantation, so we performed the full isolation of the splenic artery up to its terminal branch to the secure sufficient length on adequate caliber. This splenic artery passed under the stomach to the least graft. Since the graft left hepatic artery originated the left gastric arteries, we retraced the artery, we retraced the graft slightly and performed the anastomosis. This approach allowed a tension-free connection while accommodating small vessel size, typically in pediatric case. This is PS Doppler by sound, and we check also the hepatic artery flow by branch opening, and after the clip, the hepatic artery is very good. Alternative artery. There is no evidence for the living donor liver transplantation. We see alternative artery is best. However, some reported for this is the DDLT. Splenic artery have the long-term graft survival and biliary complication. So this report show that the had conclusion. If unusual hepatic artery, the splenic artery is first for the DDLT. However, no evidence for the LDLT. Ladies and gentlemen, this is my summary. Hepatic artery anastomosis is a key factor. Have three. One is recipient artery selection, and second is quality and length of graft artery, and third, appropriate anastomosis techniques. Importance of graft artery quality is very important. So we preserve all hepatic artery, left, middle, and right hepatic with second branches. If the late hepatic artery is unusable, consider alternative inflow source as right gastric epiflow artery, splenic artery, jejunal branch, or mid-colic artery, or etc. However, final choice must be tailored to patient condition. Thank you for your attention.